A lot of people will be hearing about deaths, sudden deaths, where someone died maybe in their sleep or they suddenly collapsed and died, and their perception would be that this was because of a heart attack. It's very important that you differentiate a heart attack from an arrhythmia. And that's essentially what I'm trying to do today. And largely, the reason is because when we see some of these papers, and this one was just published recently about sex differences in outcomes of young adults hospitalized with first myocardial infarction, which means a heart attack, from 2011 to 2022. And it shows a gradual increase in the trend. And so, what you're being told is that the patterns that you are concerned about are not necessarily based on science. It's in your head. You're observing this, but it's not actually real because the trend is still very gradual. Well, what I'm trying to do here is help you to help others to understand the difference between a heart attack and sudden death. Now, the two can sometimes overlap, but it's a very small percentage of patients who have a heart attack and then immediately go on to have sudden cardiac death. And the reason is simple is that the blood supply to the heart is obstructed. And usually people get symptoms first. They get chest pain, they get short of breath, they may be sweating, they may subsequently collapse before, say, an ambulance arrives, and they may then have an arrhythmia which causes them to die or their blood pressure goes too low. But it's not usually seconds. Very important differentiation. So, what I'm going to take you through is a bit of the paper and give you some of the science about what really is happening. So, here in the paper, they looked at ages, young adults, 18 to 54 years old, and they took 2011 to 2022 in the United States. I guess they could have gone up to 2024, maybe, but maybe they wanted to keep that trend to be relatively accurate. But let's not get into that. They looked at a large number of heart attacks, 945,000, almost a million in young adults, where 37.6% were ST elevation MIs, myocardial infarctions. I'll show you what this means in a second. And the vast majority were not ST elevation myocardial infarctions. And essentially, they were looking at inpatient, in hospital mortality that increased for the ST elevation MI, which is not surprising when you understand what the patterns are with regards to that term, STEMI versus NSTEMI. And so here are just some basic principles that I'll show you. Here is a heart. And on the left, you have here the heart. And you can see the major blood vessels and veins. Red is artery, blue is vein, coming down. And what you have to remember is that anywhere along this, whether or not it's a tiny branch or the main artery, if any one of them gets blocked, it can damage an area of the heart, and that will cause symptoms and a heart attack. So, in effect, in a simplistic way, usually STEMIs are higher up and bigger in the sense that the clot or the area that has been blocked is higher up and therefore takes out more of the heart. That's a simple way of looking at it. And on the right here, you see a cross section of the heart. And usually when we talk about ST elevation MIs, usually what it means is that there is like a hole in the heart. The whole of this muscle is dead. And this is why we see unusual patterns with the ECG. You have to remember with another kind of heart attack, it may only damage a small area here, and that would still be a heart attack. It just didn't take out the whole of a section of the muscle. And so this is an important differentiation when we're thinking about heart attacks. It doesn't matter which blood vessel, any blood vessel can be blocked. And it's usually by plaque disease. And this is usually, again, an important point for people to understand. Here you have a healthy artery. You can imagine it on the surface of the heart. This is a cross section, nice and clean, very nice, smooth lining on the inside. This, however, represents coronary artery disease. In this case, the artery is narrowed, and you have this yellow area here represents plaque. And this is an important point because over time, as the blood supply, and this is what causes angina. So, not enough blood, 50% of the blood supply is reduced. The person is running up a hill, they can't get enough blood to that section of the heart, so they have chest pain. When they stop, they feel better. And that's essentially what happens over time. But these plaques can rupture and then block the blood vessel completely. And that's the point where you can get a heart attack. Does that make sense? In angina, there's reduced blood supply. In a heart attack, the blood vessel is blocked and an area doesn't have enough. Now, when you look again, this is an example of what we would call most likely an ST elevation MI. You can see here that this artery higher up is blocked, and all of the blood vessels down below are taken off. And you can imagine looking at this heart, this area would not be contracting. It effectively is dying and will die in a few hours. And this part of the heart, depending on the size of it, if it's much bigger than that, it's no surprise somebody can't actually pump blood around their body. This is why their blood pressure will drop. And you can see here the example of a blocked artery here, down here. The plaque has ripped and blocked it off completely. And this is why they then need urgent specialized procedures to try and open it up. If they don't have it in time, this whole area can get damaged. But it's important to remember that this is a big area of the heart, and this would represent what we call an ST elevation MI. In reality, it probably means a bigger area of damage to the heart, because even a small branch of a blood vessel can still cause a heart attack. It could do just as much pain, make you feel short of breath. But when you look at the arteries, they are largely open still, and only a small branch is blocked. Sometimes you may have people who have had angina for years and they're struggling even on minimal exertion. And guess what? They have a heart attack and their angina disappears because it was just a small branch causing all their symptoms. Quite remarkable. So it just depends on where and how much of the heart is damaged. So when we think of the ST elevation MI, this here represents normal beats. This is representative of the ventricle contracting. That's what we call the QRS complex. Nice and clear, moving along. In an ST elevation MI, looking at, say, one lead V2, instead of this ST segment here being flat, it's raised. And this is what you would see on an ECG. This is a normal. This is an example of an ST elevation MI. And it usually means that the whole of the muscle in that area is damaged. So it almost points to a bigger heart attack. And this is why it's taken so seriously. And when we talk about full penetration, you have to remember that this is the inside lining, the endocardium, very thin, thick muscular layer. Then on the outside, you have the epicardium, then the pericardium. So this whole section of the endocardium, the myocardium, epicardium could get damaged and cause a hole that causes the ST elevation on the ECG. So when we talk about that, it's an ECG finding, and it means that that area of the heart has been significantly damaged. So it's no surprise that they have worse outcomes. But the symptoms can be very similar in terms of chest pain, shortness of breath, sweating, feeling unwell. It just depends on how big that artery has been blocked. And when we look at the patterns in terms of the histology, within about 12 hours, you can see that some of these muscles here are dying. By 72 hours, you have infiltration of immune cells. More are dying. Then by 3 weeks, this starts to get fibrotic. And at 1 month, this area then is now fibrotic. And you would find if you looked at an echocardiogram that that area of the heart just wouldn't be contracting. And it's a permanent scar to the heart because of this ST elevation. So the main reason why it will happen is usually because of plaque disease. Now, as I was reminding you, that this mechanism is very different from sudden death, and we'll come back to that in a minute. But as you can see, when an artery is blocked, it causes immediate symptoms, but it doesn't usually cause somebody to just die. Very rarely will it do that. When we look at the arteries, and this is why it's relevant post-COVID, what causes the plaque is an accumulation of fatty deposits in specific immune cells in the muscles, and it then pushes it up, causing obstruction. And this cholesterol, this is why we're focused on the cholesterol, is deposited in these immune cells, primarily macrophages, in the lining of the blood vessels. This excessive accumulation, because of inflammation, can then cause vascular disease. And this is part of the reason why people forget that technically a heart attack is a vascular event, an inflammatory event. And this is what then causes much of the problem. And you can see again here, example of a plaque blocking a blood vessel here, thick layer of plaque along the sides, and inner muscle layer. And all of this is relevant to causing an ST elevation heart attack. And this is relevant to the reality. When we look at the paper, back to the paper now, and this will now make more sense, is that in hospital mortality for the first ST elevation segment myocardial infarction increased significantly, but it remained the same for the non-ST elevation myocardial infarction, which tends to be smaller. But they're finding that in younger people from 2011 to 2022, this seems as though it has been increasing. Now, I would expect that to happen as well when I look at the mechanisms around plaque disease and what happened in the pandemic and post-pandemic. But just the same, the trend was already on the increase. When we look at the overall baseline cohorts here for first myocardial infarction, you can see the different age groups, 18 to 34, 35 to 44. I've highlighted 45 to 54. 70% of them for both NSTEMIs and STEMIs were above the age of 45 to 54. Only a small percentage were 18 to 34, and this remained relatively similar over the 2011 to 2022. Men greatly outweigh women, and if you notice for NSTEMIs, significantly more for STEMIs, 77% to 22.8%. So men tend to have more significant STEMIs than women, and there are a number of reasons for that. Hypertension tends to be more associated with NSTEMIs versus STEMIs, but it's flipped around for tobacco. Tobacco use here is very strongly associated with STEMIs, blockage of the arteries. And this is largely because the cigarette smoke damages the endothelium and it causes increased plaque disease. So all of these are factors that are quite relevant in terms of understanding the risk factors around the disease. And you can see here in terms of mortality in the paper, where people died with their first STEMI, it's been a gradual increase over the period of time. At this point here, females in orange are at the highest level that we've seen. It's an interesting question as to why women would have a higher risk in terms of their first STEMI for mortality, even though men are more at risk. So this is important for us to try and tease out. Is that a pandemic pattern? You may note, and I've now expected that in reality, they never mention anything about vaccination status. I've given up asking for that because it doesn't look as though it's relevant, but we'll leave that alone. But the point now is that when we look at these conditions, when we look at what is happening with plaque disease, It explains an important point, and I want you to be well educated on this because I've noticed that patients are more and more concerned about the use of statins. Now, follow me here. I'm not getting into a controversy here. This, as I said, is an example of this is the lining of the blood vessel. And you can see here these macrophages, they start to pick up all of this cholesterol and they package it in, they get trapped underneath here, and this is what causes the plaque. Now, because this is caused by elevated lipid nanoparticles floating around in the bloodstream, statins come into the picture. But hear what? Now listen very, very carefully. And this is a conversation that I have to have very often. Now, I think that they overused statins when I go back, say, 10, 15 years. They were tremendously valuable at preventing plaque disease and therefore reducing the risk of ST elevation MIs. However, I think that it almost went too far the other way. So too many people got side effects, told all their friends, and so therefore nobody now wants to use statins. But hear me very carefully. If you've got risk of plaque disease, these statins do a number of things. They reduce the platelet activation, they help with coagulation, they have critically a very important impact on macrophages that drive the plaques. Usually what I explain to people is that it's not so much about cholesterol, but it's about them stabilizing macrophages and helping to reduce plaque. This is one of the biggest reasons why we need statins, especially in people who have had disease, whether or not it's a mini stroke or a heart attack, or they have peripheral vascular disease, where you know they've got plaques. Statins help to stabilize them and reduce the risk of it happening. So this is a very important point. Now, coming to this question again of sudden death. Sudden death is not necessarily the same thing as a heart attack. As I said, somebody can die suddenly and because of a heart attack, but it is not the typical presentation. So when you hear of those stories where someone has just collapsed with a cardiac arrest and they've got defibrillator pads on them, very often this is not because of a heart attack. They've had a cardiac arrest, but it's not necessarily a heart attack. Very important difference. And how you understand that is when you look at the ECG principle. This is a normal ECG, as we said, normal rhythm. And you can, every time you see a spike, that's when the ventricle contracts the QRS complex. In a cardiac arrhythmia, this is what happens. Instead of the normal spike, suddenly the heart does this. When the heart does this, it is no longer contracting. It's almost as if it has stopped. It's fibrillating. It's just twitching if you were to look at it. If somebody has this for more than about 5 minutes, they are not going to survive because they no longer have a cardiac output. This pattern is not necessarily, or in most cases, not connected to a heart attack. This is where I'm saying that you have to be very savvy in terms of talking about these things. The heart attack can sometimes lead to an arrhythmia, but it's a small percentage of patients, and usually they have a prodrome of symptoms. They were short of breath, they had some chest pain, they're feeling as though they were going to collapse. They then collapse. That may be the point at the arrhythmia. But if somebody goes to sleep and just doesn't wake up, that's likely to be an arrhythmia rather than a heart attack. If somebody is just walking and just suddenly collapses, that's likely to be an arrhythmia. So if you see it happen in the sports field where a player is playing and then collapses, it is almost always going to be an arrhythmia. For whatever reason, the heart is triggered into an abnormal electrical rhythm, and then the heart technically stops. That's the bit that we need more clarity on, because based on my the science around myocarditis with focal areas of inflammation and scarring. Any one of those scars could potentially lead to an arrhythmia if it's triggered enough. If somebody, this is why in a younger person, if they are overexerting themselves, this is why nowadays you're finding that everybody needs to be screened if they're younger to play sports. If they were using drugs and they take cocaine and they have these areas of damage in their heart, it can trigger an arrhythmia. That is different from a heart attack. And this is the bit that we need to explore. This is why I want autopsies. I am looking for focal myocardial fibrosis as the main reason why it appears that there are more people dying suddenly with no clear cause. There's so much work to be done. And the reality is that as we now see war across the world, the Epstein files are distracting everyone. The COVID pandemic appears to be behind you. All we will see now going forward are the outcomes. At least my hope is that more people will be educated, better informed, understand the right questions to ask. Make sure that you can then push people to at least try and do the right investigations. Have a great evening. Look forward to bringing you more science in the near future. Final point, remember, coming up shortly, Embalmers White Clots Myths Resolved. This is about my third time tackling this. Very important conversation, some very interesting scientific things that I've come across in the past few weeks. I'm hoping to share it with you. Have a great evening, and we will speak again soon.